Without further ado, please join me in welcoming our speaker, Mr. Jack Ashby.
Thank you, Matt. Thank you, and I'm delighted to be here to talk about what I think is a very important and cutting-edge topic. I'd like to also just take the moment to send greetings to the neighbor islands. I think it's wonderful that we have this technology available for us to reach out across the state. As far as I'm concerned, we can stop and ask questions along the way. I don't know if you have a usual format for that, but you know, if you have something to ask, feel free to just chime in. Okay, I had this first slide of sort of the agenda of what we were going to go through, which we've already covered. So I think I'll just go right ahead and get started. First, though, is sort of the problem that we are dealing with, and I'm not going to dwell on this because I think you've all heard it before. But in essence, the problem is that our fee-for-service payment system doesn't really encourage either high quality or efficient use of services. And we've had quite a bit of activity in the last several years on pay-for-performance or pay-for-quality systems. So that's an important interim step that has provided an incentive for high-quality care. But we're still in need of a payment system that will incent providers to provide the right mix of services in the right order. And because that does then cut across multiple providers, we need a system that encourages coordination in the delivery of care across the various providers. The goal of accountable care payment then derives directly from that problem statement. Is to drive improvements in the quality and efficiency of health care by aligning the incentives that physicians and hospitals face, or in other words, to get everybody working towards the same goal with the same incentives, and then to improve providers' processes and coordination. Or, in other words, having the incentive alone isn't necessarily enough. We need to actually reform, change the way services are delivered. The term Accountable Care Organization, or ACO, I'm sure that we've all heard it. And the thing that I wanted to emphasize first is that this is an organization that we are talking about here. And we would define it in terms of a collaboration of providers, and I would add a voluntary collaboration of providers across various settings that are coming together to assume responsibility for overall patient care. Now, clearly, hospitals and physicians are the key players here. That's what we always start out with. But over time, we want to extend this into other types of providers as well. And the ACO organization can take a variety of different forms. Just a couple of examples. It may be one integrated hospital system or a hospital physician organization, but it also could be a loose affiliation of independent physician practices and independent hospitals. It could be a hospital-led organization, and that's the most frequent scenario, but it also could be a physician-led organization. Okay, in this next slide, really our key slide here, we show the three forms of accountable care, and these are intended to be a progression moving left to right. So let me start with the patient-centered medical home. This is focusing on primary care practitioners, and the key issue here is that we are moving from paying a la carte, paying for each and every service, a visit, a lab test, whatever, to a hybrid system, we could call it. We are still maintaining some fee for service, but we're adding in a per person or per capita management fee for the physician. And actually, I'd add that we're also experimenting with the idea of making it a completely a global or per capita rate and doing away with fee-for-service altogether. But that's just sort of a experimental stage. But you can readily see now that once you pay for the person, then that opens up the possibility of thinking about how can we care for that person in the most efficient way possible, and it may not be calling them in for regular visits. It can be much more advanced than that. In the next slide, I first wanted to note that HMSA is making a major commitment to primary care in the form of PCMH. We have now about 50% of all primary care physicians in the state in our medical home project, and also about 50% of our 700,000 members are in a medical home. The idea here is the medical home serves as a central resource for patients' ongoing care. They'll be providing service directly, emphasizing preventive care, but also hopefully coordinating the care that patients receive from various sources. And I just had a list on the next page of some of the key features that you would expect to see, and you might begin to see evidence of some of these things with the physicians that you visit yourselves. First of all, of course, is to make sure that every person has a unique primary care practitioners. But then the idea is that the PCPs will work as a team with support staff, and this can be things like diabetes counselors, dietitians, pharmacists, health coaches, and so forth. Once we get away from paying only in the form of physician visits, opens up the possibility of other ways to deliver the services that patients really need. And the same with communication. We expect to see much more use of phone or email, which will again serve to sort of minimize these in-person visits. And that once again is tied directly to this incentive to provide overall care rather than to just get paid for visits. We expect to see the physicians using their electronic medical records, which all of them will have before too long, to identify gaps in care. These could be things like patients with obesity problems, diabetics that are not controlling their glucose and so forth. And then they would reach out to the patients rather than waiting for them to call in to get an appointment, and do things like discuss screenings that are necessary, review lab tests. In general, talk to the patient about ways to improve their health in a proactive rather than a reactive way. Okay, now I want to return back to our matrix here and move to the second tranche, which is bundled payment. Now here we could be talking about specialty care, cardiac, orthopedic, and so forth, as well as primary care. But the key difference here is in the second line, where the payment unit is now the episode of care. And we would define an episode as encompassing all health care that occurs between the onset of symptoms and completion of treatment. And we have a little diagram here to sort of exhibit how that works here. We have the simple case of a boy with a broken leg. When he goes to the emergency room, that emergency room visit triggers the episode. It's the indication that we have an onset of a condition here, the fracture. Then we're picking up all related care, which would be first the x-ray and then a cast and maybe some pain medication, follow-up visit to a specialist, whatever the case may be. And then we recognize the end of the episode when we have a span of time, a designated span of time with no related care having been provided. It's usually on order of 60 days or so. We assume the episode is over if they haven't gotten any care in that amount of time. So that's episodes. Now, again, returning to our chart and moving to the third column for what we call the full ACO model. As I said before, an ACO is an organization first, but it also spawns a payment system for care provided by that ACO. We're first, though, covering all care that is typically covered by an insurance policy. So we've gone to the broadest level here. And the unit of payment now has moved from an individual episode of care to all care. or a per capita measurement. And that means that we now have to identify a population that is covered by the ACO. Whereas back in episode, you could just take all comers as they arrive. Now we have a designated group of people that the ACO is responsible for all care. This is just a simple diagram here to exhibit the fact that this is a progression as we move from fee-for-service across to medical home, to bundled payment, to full ACO. We are gradually expanding the importance of data on patient care for managing care. We're expanding the accountability of the providers involved for certain. We're expanding, hopefully, the coordination of care and the efficiency with which care is provided, and that all leads, we hope, to the potential for ever greater savings as we broaden the scope here. Now, one of the questions that we are often asked is, well, if we have moved to the person as the unit of payment here with an ACO, well, isn't that basically capitation that we've known for 20 years? Is this really any different at this point than an HMO? In some ways, it is different, and that is begins with the basic incentive. Now, we as we've said, sort of labeled the incentive that an ACO has is to improve both the quality and the efficiency of care. And one would hope that that would be the same objective for an HMO, and often it is. And I like to cite Kaiser as an excellent example of a staff model HMO that absolutely is within this sphere. But in practice, particularly in the past, back in the 90s when we had this great era of HMO expansion, in practice, that isn't what was really happening. In practice, what the HMOs were about is various ways to restrict services. It gets you to get approval for this and that, and also, I would add, to restrict the payments that are going to the providers. A lot of that HMO era had to do with finding ways to pay hospitals and doctors less without paying any attention to the services that they really are providing and whether we're really improving coordination. But the key differences come on the next couple of lines. The HMO typically asks the patient to commit to a specific physician for at least a year's period of time. The ACO is not making that requirement. We hope that you will develop a relationship with a primary care practitioner, but the idea is that you can you can change physicians anytime you care to. And this is very purposely sort of a reaction to people disliking HMOs in the past because they really don't want to be stuck with a physician. If something goes wrong, they want to be able to go out and seek care elsewhere. So we're trying to accommodate that. Similar on the next line, typically an HMO requires the patient to get their PCP's approval before seeing a specialist or having surgery or anything along that line. That requirement doesn't exist here with an ACO. Again, the hope is that people will do that. They will develop a good relationship with their physician and they will want to consult and have that person managing their care, but it is not a requirement. Then sort of a similar theme on member assignment. With an HMO, you got to pick the HMO as your coverage. That's done in your HR department, usually at the beginning of the year. With an ACO, there is no member selection. The process is really invisible. The patient is assigned to a PCP based on just looking at their track record of what physician they go to, and then if that PCP is in the ACO, the patient is assigned to that ACO. It's a process that the patients might not necessarily even be aware of until their physician brings it to their attention. Okay, next we were going to talk a little bit about some of the key design issues in accountable care payment, but I realize that this could be getting into the weeds here, so I'll try to keep this kind of at the highlight level. But as I'm sure that many of you in health planning appreciate, frequently the devil or the angels is in the details. It matters a lot how you develop these programs. First issue is, well, what clinical domain, what care are we going to cover? If we're talking about the ACO, well, it's all care, so that answers itself easily. If we're in the bundled payment about episodes, the two most common ways of going about it are, first of all, to look at surgeries so that we create a package deal for the surgery. You deal with one set of providers that will coordinate with each other, and hopefully even one copay for the entire arrangement to make the thing more user-friendly. And the other focus point is chronic conditions. This would be things like people with diabetes, chronic kidney disease, chronic respiratory problems, and so forth. They are the ones that often can benefit most from a proactive treatment plan and coordination of care. Next issue is a very critical one, and that is that there are two ways to structure the payment arrangement. And I'll go to the second one first, actually, and that is that we can create a fixed payment rate. We have one payment rate for the entire episode of care, and then the providers split up the money. And that is essentially the most advanced way to do it. But most of the time, providers want to start out with something that's a little bit less risky. And so we have applied the first model, which we call shared savings. And the way this works is that the providers are continue to be paid fee-for-service like they always have, but we're aggregating up the services into the episode, and then there's a financial reward if they keep the episode costs beneath the agreed-upon rate, and for the full ACO, if the entire per capita cost is below the agreed-upon rate. And I got a little chart here on the next page that just sort of simply depicts how that works. You look at the trend, what's been happening to your per episode cost. You project that out to the next year, and that becomes your target rate. And then there is an arrangement for sharing any savings that result from coming in under that target rate. So one of the decisions then is, well, what's the sharing arrangement? Is it 50-50? Is it 80-20 and so forth? And as you can imagine, that leads to a lot of discussion. And then perhaps the most contentious issue that has evolved in ACO is, well, what happens if there are no savings? What happens if the cost per episode is actually higher than your target rate rather than lower? In most arrangements, we're starting out with a risk-free experience for the providers. So if there are no savings, they get no reward, but they don't lose anything either. Over time, though, clearly the goal is to get to the arrangement where providers have skin in the game as well. They have opportunity for gain, but they have risk of loss as well if the performance isn't there. In the long run, that's going to be the mechanism that will work the best, we think. Then there is a decision about how far to go in defining your episode. Many of the first tries at bundled payment have stuck with just the hospital stay. So now all you're combining is the physicians and the hospital. But the physicians, of course, can include the attending and a hospitalist, can include consults, an anesthesiologist, and so forth. The more advanced way, and clearly where the savings are, is to go to number 2, which combines the hospital stay with up to 90 days after discharge. So here you're picking up the two biggest sources of variation in episode cost, and that is use of post-acute services like skilled nursing facility or rehab center or home health and so forth, and the possibility of readmission back to the hospital. That's the most expensive outcome of all, and that's what we really want to try and avoid. Then we could move to all care associated with a certain surgical procedure, and finally to the entire episode. Everything that happens between when the condition starts and when the treatment is completed. Related issue is we typically start out with just hospitals and physicians. We clearly want to move over time to bring in skilled nursing facilities, rehabs, mental health, definitely hospice into this picture. But as you can recognize, the more provider groups that are involved, the more complex the arrangements have to be. And so this is a real challenge to make this work organizationally to deliver the kind of coordinated care that we're looking for. And then final issue is quality. There's been quite a bit of discussion about this as well. One approach is to continue with the pay-for-quality kind of program that we already have. So you got one pool for rewarding high-quality care and a separate pool for rewarding bending the cost curve, if you will. The other way to go about it is to sort of keep quality as a separate matter and just set up minimum standards for quality, because you don't want to have risk of deteriorating quality because the providers are getting a fixed payment and then not doing anything, if you will. So you have to guard against that, and we do that with a set of minimum quality standards that they must meet in order to qualify for any of the shared savings. Okay, now I wanted to go over a little bit what Medicare has been doing in accountable care. They indeed have been a leader going back to the health reform bill and even before. First of all, they had a demonstration of bundled payment that's been going for a couple of years, and it has really worked out rather well. It only covers the hospital stay, so it's sort of limited in scope, but they have documented savings up to 6% from their participants, and you know that's not huge, but it's well worth bothering with, particularly since it is narrow in scope, and they're now looking to expand it. Then Medicare came out with its ACO program, and I wanted to emphasize here that this is not a demonstration project. This is a program, and any provider group in the country may participate if they can get themselves organized to meet the requirements of the programs. And this is now in process, and CMS says at least that they are going to have this in operation with some groups by April of this year. A couple of things about this. One is just as I described. They assign the patients to the ACO in a process that's basically invisible to the patients. There's no sign-ups, no restrictions of any kind. They have set up a 5,000 minimum. It takes a certain scale to make this work well. Then, just as I described, they have a 3-year trend of the cost per capita, and they use that to develop a target. And then, as they've set it up, the providers can get up to 50% savings without any risk. Or if they're willing to accept the risk of having to share in losses if they should occur, they can get up to 60% of the savings. I think we can be assured that everybody's going to take the no-risk approach, but that's to help get this going. Just a couple of other things. They have said you have to have at least 2% savings in order to get paid, if you will. That's really a reaction to the possibility that the savings might come from sort of random variation in your costs rather than true change in the way care is delivered. And then they do have minimum quality standards that need to be met. Then Medicare came out with what they call their ACO Pioneer program. And this, in a nutshell, is the same as the shared savings program, except that they have moved from, by year 3, they are going to begin moving off of the shared savings approach into a fixed payment rate, a fixed per capita rate paid to these provider groups. So this is, again, really getting rather advanced. They're almost to the point of doing exactly what HMOs do. And this is designed for groups that really have a lot of experience in providing coordinated care. Medicare also has a bundled payment initiative. The hospitals can choose the clinical conditions that they want to participate in. They might go for only cardiac care, might go for some orthopedic procedures and so forth. They develop a target rate for the episode, and again, the providers can share in savings if their sum of fee-for-service payments does come in under the agreed-upon target bundled rate. And they have set up 4 different programs here. The first one is, again, our inpatient stay only. Then the second one expands out to include post-acute. The third one is really a strange beast, it seems to me. They're going to offer the possibility of a deal only with post-acute providers, with SNFs, rehab centers, and that sort of thing. It seems to me that it kind of violates the very principle of this. We are looking for coordinated care across acute and post-acute, and paying two separate rates doesn't seem to me like it really gets you there. But be that as it may, they have offered that. And then they're also going to offer an opportunity to go for the fixed rate, the most advanced form. And then finally, I thought I would talk a little bit about accountable care payment in Hawaii. As I described before, HMSA has made, expended a lot of resources in implementing patient-centered medical home for all physicians in Hawaii, and we're about halfway to our goal of getting this implemented statewide. We also have placed great emphasis on pay-for-quality systems, and we have every single hospital in Hawaii, except the critical access hospitals, on this system that rewards them for high-quality care, and we also have all of the primary care practitioners on a similar system that rewards them for high-quality care. But when we get to the bundled payment and the full ACO that we've been talking about, there are no operating systems as yet here in Hawaii. To the best of our knowledge, there were no hospitals that applied for the Medicare Bundled Payment program. There were no groups that went for the Medicare full ACO. HMSA is very definitely open to the possibility of developing arrangements both for our Medicare patients and for our commercial payments, and there have been some preliminary discussions around the state. But we think the concept has a lot to be said for it in terms of expanding coordinated care, and we're anxious to work with some groups to try it out. But you might wonder, why is it that we don't have any programs in Hawaii yet, whereas in some other states there are some that are operating already? But there's a number of factors. And for one thing, we already have fairly extensive coordinated care through HMOs. We have Kaiser. And, HMSA and Kaiser are friendly competitors, so it doesn't bother me at all to kind of give them a push. They have done a lot in this area, and other areas don't have anything like that, so they have more ground to make up, if you will. Second factor is that HMSA's payments are already partially bundled. We have gone as far as using, you've probably heard of the DRG payment system, per case payments for all hospital care. So that already bundles everything that happens during a hospital stay into one payment. We also have one payment for surgeons that bundles together the actual surgery and follow-up visits. So more than one person has kind of wondered out loud whether there are enough touch points left that are not already bundled to make this concept work. We still think there are some possibilities here, but again, perhaps not quite as much as in some other areas. And then I would also add that in many parts of the country, one of their top goals is to try to bring post-acute services, this is skilled nursing care, rehab and home health, under control, because it has been growing wildly out of proportion in the last decade or more. But we don't have that problem in Hawaii. As health planning people know all too well, we have a shortage of skilled nursing facility beds, not an excess. And so controlling use there is not something that needs to be worked on quite as hard through the payment system, because unfortunately the capacity constraints are limiting it already. Then I'd also point out that outside of Kaiser, we don't really have the degree of integrated delivery systems that we see in some parts of the country. And then, after I put this together, I really thought of another factor. It was kind of reminded to me in a webinar that I was attending yesterday with David Wenberg, who you might recognize from Dartmouth, one of the leading people in this field, who was reminding people that if the ACO concept produces major savings, it will be for the reason that we all know, and that is because we're controlling the use of hospital, inpatient hospital care, the most expensive and sometimes unnecessary type of care. Well, once again, we're already doing that in Hawaii to a very significant extent. Hawaii's hospital admissions per 1,000 population is the lowest in the country, lowest of the 51 jurisdictions. So while we on the one hand think that definitely there's still progress that can be made, fact is we don't have as far to go as some other parts of the country do, and consequently our premiums are considerably lower than some parts of the country. So that's it. Any questions? All right, Deb.
Okay. Well, thanks so much, Jack. That was a great presentation.
Oh, thank you.
My question is, you had said the ACO doesn't have restrictions on the providers that a patient sees.
Mm-hmm.
But let's say a patient is seeing a provider in the ACO, so they're getting, considered to be part of that ACO, but they're also seeing all kinds of other providers. Is the Medicare going to pay fee-for-service and then a capitation rate as well?
Yeah, this is you've hit on the dicey part of this, because the providers are on the hook for that. Well, actually, let me answer it in two ways. First of all, the patient has to have a plurality of their care provided by a single, a certain minimum amount of their care provided by a single practitioner in order to be in the program at all. So if they're going to 10 different physicians, and every once in a while you do see patients doing that, they literally just shop their way around. They wouldn't be in this program because they couldn't qualify. But the problem that you talk about is still very real. You can indeed have a scenario where the patient is assigned to this ACO because they use that primary care practitioner, and then the patient just simply wants to have a second look at it, or gets annoyed with the physician and goes somewhere else. That original group is still accountable for all care that the patient sees. So the first thing they're going to want to do is get information on what physicians the patients are going to. And if they see evidence that they're going to 5 different physicians, they're going to want to talk to them about this. This is not the way to provide good quality care. But in the end, all they can do is cajole. They can try their best to provide the kind of service that's going to keep the patient in-house. The rules are that you can't stop them from going to somewhere else, because our thought is if you do that, you're right back to the HMO scenario, and we all know that there's a lot of people out there that just will not join an HMO because they won't stand for somebody telling them that they can't go to another physician if they're dissatisfied with their first one. So we have to finesse our way by that, and for all I know, Deb, it may be that becomes a real stumbling block and gets in the way of some groups being able to accomplish what they set out to do. So.
Yeah, I was wondering, what do you think the physicians, say office-based physicians' attitude is towards accepting the capitation? I mean, I know in the past they're kind of wary of it and they're afraid of it. They don't really know how it's going to turn out and the risk involved. Is that holding back a lot of this? I mean, I know they have some bundled already, but...
Mm-hmm. Well, now this...
Is there a day where you might force them into this sooner or later and say, look, this is just the way it's going to be?
I'd like to hold off on suggesting that we want to do that. I mean, who knows what the future holds, but clearly we believe in the concept, obviously. But from the physician's perspective, we have encountered a variety of reactions to this. We have some physicians who are very enthusiastic about the idea because they really recognize that they haven't been in a position to do good coordinated care, and they don't like the idea that they can never get paid without bringing the patient into the office. They know perfectly well that there are other better ways to provide care, but they can't do it because they aren't going to be able to make a living if they don't get the patient into the office. There are, quite frankly, though, other physicians who are just kind of vested in the way things are done now and are not particularly enthusiastic about it. And I think it's just going to be a very slow eventually it'll be a sea change, but now it's just trickling in because it's totally reforming the way people think and the way they do things, and that's a difficult experience for some. But I think we can definitely say, though, that on balance, we've gotten a pretty good reaction from the physicians to the concept, as evidenced by the fact that it only took us a little over a year to get half the physicians in Hawaii to participate. They didn't have to. They, we went out and presented the idea. We definitely were selling it, but they agreed voluntarily to participate. And so I think that's a pretty good sign. Any other questions? Surely we can get one more, make a threesome.
Yeah, I have a question.
Okay.
So historically, HMSA, it's there to pay claims.
Mm-hmm.
And so this change in how payments are made is not going to be based on claims data.
That's exactly right. That's a really good point you're making, and I probably should have said more about that too. Here I was talking about the sea change in attitude and approach that primary care practitioners are having to do. Well, the same goes for HMSA and other health plans, and that's why we purposely call ourselves a health plan now and not an insurance company, because our job is going well beyond paying claims anymore. In fact, that's the easier part of the job, and creating a system that provides coordinated care and provides the best quality and the lowest cost care is a far more challenging job, and a lot of our resources are tied up in these kinds of things. We still pay claims, and I'm sure we will for a long time to come, but that isn't the, if you were a fly on the wall with all the meetings and the initiatives going on in our building, you'd find that a lot of it has to do with how care is delivered now and less on paying claims. All right.